afternoon, good morning, good evening, depending on where you are around the world. You're welcome to our 8th webinar. And this is part of our series of webinars that we do, which is organized by COVID Nigerian Medics, and it's a now registered charity, Concerned Medics Foundation. I would like to start by acknowledging the sober mood the nation is experiencing since the news of the tragic death of our gallant soldiers. May they rest in eternal peace. Amen. I am on call just to warn everybody in case I get called, one of the panel members is going to take over. So since the start of COVID, we have done monthly webinars, mainly on health-related issues in Nigeria. And today we will be focusing on drug addiction and the Nigerian youth. This is so relevant in our society, and it's so common. I'm sure most of us would have come across maybe family members, colleagues, neighbors that, have been afflicted with, or have had a drug addiction problem or have overcome it. And as we know, drug addiction, it does not, it's not just the poor that it affects. It's common in all, societal settings. And if you've been listening to the news recently, even Prince Harry here in the UK had disclosed the use of drugs and alcohol to numb the pain of losing his mother. So, it's just all across the board, we're seeing this problem, especially more so in Nigeria. So today's webinar is going to be just 1 hour, 30 minutes. So the first 45 minutes, I'm going to share my screen so you can see, the agenda for today, the plan. So an outline is I would take the first 45 minutes, and what I will do is I would introduce the panel members. We've got 8 fantastic panel members. I will introduce them and ask them specific questions. And the next 45 minutes, our second moderator, who has got 2 roles today, would be a moderator, and he would also he is also on the panel at the moment. He will take over, and this will be more of an interactive session. So you have plenty of opportunity to ask questions to the, to the panel. What I'm going to do is I would introduce Dr. Aisha Abdullah Joda. She is a pediatric doctor like myself. I'm Dr. Sadia Gumi. I'm a pediatrician. I forgot to introduce myself. So Aisha is a colleague. She is working for Her Majesty Courts and Tribunal Services. And she's also planning setting a healthcare NGO to build and run a women's and children's hospital in Yola in Nigeria. So she will be reading out all the questions, and at the last, the second half of the webinar. And my co-moderator is Professor Abba Aji, who is here with us. He is a young adult psychiatrist and clinical professor in Department of Psychiatry, University of Alberta, Edmonton, Canada. He's a fellow of Royal College of Psychiatrists, UK, a fellow of College of Physicians and Surgeons of Canada, and also a fellow of American Psychiatrists Association and Royal Society of Medicine. Professor Abba Aji has served as the lead psychiatrist for the Young Adult Assessment, Evaluation and Reintegration Program at the Alberta Hospital, Edmonton. He also serves as the lead psychiatrist for Edmonton Access Open Minds, which is part of the $25 million Canadian Institutes of Health Research. So this is an initiative that engages young adults with addiction and mental illness. So they will be helping me as the co-moderators. So starting first with, on the panel, we have 8 members altogether, and they come from, they're doctors, they're counselors, they're, people that want to share their experiences regarding drug addiction. So it is really a fantastic opportunity today for, to hear from the experts and have an opportunity to ask questions and, rub heads and minds together. So the first question I'm going to throw it to Professor Taiwo Latif Sheikh. He's a professor of psychiatry, ABU Zaria. And I can't really do justice to his CV, to be honest. He's got so much experience that I just decided I'm going to summarize it. So amongst his many roles and responsibilities, he's currently the National Secretary for West African College of Physicians. He's the President of Biological Psychiatry Society of Nigeria. He's an alumni faculty member at Harvard Global Mental Health. He's also an examiner, with Ghana, Psychiatrists, just many colleges and national and international bodies. Currently, he's engaged in training and supervision of undergraduate and postgraduate students and resident doctors in the field of mental health. He has also authored and co-authored many peer-reviewed journal publications. So it's really an honor to have you here with us today, sir. Thank you for coming.
Thank you.
Yeah. So my first question to you is, just in simple terms, what is drug addiction and why are our youths vulnerable to substance abuse, most especially in Nigeria?
Well, thank you very much. I just want to also, like you did at the beginning, to commensurate with the people of Nigeria, especially the Commander-in-Chief of the Nigerian Armed Forces and the immediate family members of the Chief of Army Staff and other soldiers, officers and men that lost their lives in the ill-fated flight. May God grant them eternal peace and grant the family and Nigerians the fortitude to bear the loss. Amen. Thank you for asking me this question. Let me just add that I'm sitting here also as the president of Association of Psychiatrists in Nigeria. So I'm, using the voice of the psychiatrists in Nigeria, both home and in diaspora. The question you have asked is quite valid, the issue of addiction. But before I address that question, I want you to understand that we do have a lot of misconceptions about substance use disorder, especially addiction in Nigeria. Of course, we have it also globally, but it's quite a lot here. People don't seem to understand that substance use disorders are a group of disorders under mental health disorders. They try as much as possible to take it away from mental health disorders. We do know that it is grouped even in ICD-10, in DSM, ICD-11, DSM-5, and all not as mental health disorders. It is very important that we understand this perspective and place it rightly where it's supposed to be for good access to intervention facility and those who will provide the care. Now, what is addiction? Addiction is substance dependence. We technically call it substance dependence. Generally, people refer to it as addiction. It's a chronic relapsing disease of the brain, which means it runs a long course. Relapsing is part of the criteria, and it's an illness that is seated within the brain. Addiction is not a lifestyle issue. Rather, it is an illness. And it is not everybody who uses psychoactive substance that you will call an addict. In fact, the road to addiction, we describe it as the road to hell, which starts from experimentation to casual use for certain purposes, either recreational purposes or for you to be able to carry out certain things that ordinarily you will not do, to the level of habitual use, where you get used to it and certain things you want to do, you will not be able to do it unless you are under the influence of the substance. It kind of increases the enjoyment you derive from whatever activities that you are doing. So you become an habitual user, and then you gradually move on to dependence. And dependence, by definition, is a situation where an individual can no longer function normally in the absence of the substance as a result of either the magnitude, the quantity of the substance you are using, or the duration for which you have been using the substance, or the inappropriate manner which you are using the substance, to the extent that you cannot perform normally as a human being in the absence of the substance. You feel threatened, your life is threatened in the absence of the substance. So it is not a mere lifestyle matter. It is very, very serious mental health disorder that has a very fatalistic potential and is something that needs to be looked into. Why is it so common nowadays? Why are our youths really dealing with this matter? We do know, you said something about Prince Harry's confession, publicly admitting the use of substance to be able to deal with certain challenges of life. These challenges, you find them all over Nigeria today, especially among youths. We have a lot of problems that will drive people to find succor in the use of psychoactive substances. So I cannot exhaust these reasons, but our youth are at risk. Some data we collected at AB Teaching Hospitals some years ago found that over 85% of people who come in with substance use problem are between the ages of 15 and 34. So this is the future of the country. This is the productive age of the country. And these are the people that are at risk. They are the ones that are having this problem. And if we don't deal with it, do we want to have future leaders who are leaders that are addicts? Do we want to have future leaders who will not be able to manage us well? So it's difficult to really exhaust this here, but the issue of substance use disorders, substance addiction is a youth problem. And I thank you very much for bringing this up. We have to put our heads together and see how we can deal with it. Thank you very much.
Oh, thank you very much, Sheikh. That was quite interesting to know. So I was quite interested with 16 to 34 years. Is that what you said? That was...
Yes, 15 to 34 years. Yes,
oh my
absolutely.
God. Yeah.
Okay.
I have another question, but I think because of time, I've got Hadiza Aliko Mohammed. I'll come back to you because she has to leave by 16:30. So I'll come back to you at a later date. Hadiza Aliko Mohammed, she's a counselor and she's a CEO of House of Recovery in Kaduna, and she's here with us. So she has to leave by 4:30. So I wanted to ask you, Hadiza, I know you've started a recovery center in Kaduna. Why? I know you're not a doctor, but I would just like you to tell us why you started that. Why did you think it was necessary to start a recovery center?
Thank you for having me. I went into this space after a very long time of being an angry outsider, I would call myself. So I became a mother. I became a very terrified mother, seeing what was going on, a very long time. And as I said, I was an angry outsider. I didn't understand what it was. And I felt that this is something that he caused on to himself, but, was affecting all of us. And then, I said to myself, he needs help, and he's been getting help. But then I asked, I'm looking at it as if somebody else should be able to help him. And I asked myself, so if this was, my biological child, would I now, say he should get help from somebody else? What is it that I could do? I know that I'm not a doctor, but how can I help? And I had been seeing this family member going in and out of rehabilitation and, coming out and then being clean for a while and then relapsing and then, going back. So I wanted to find out what could I do to support his recovery? So I chose to study a little bit about addictions, and I knew that I didn't want to go. I don't like hospitals, so I knew I wasn't going to be a doctor. But the idea of counseling, appealed to me. Trying to explore, what is happening, trying to help them to understand, trying to find what the root, causes are. And along the way, I felt, okay, so if I could set up something where people could come for counseling as opposed to, having a rehab clinic, because I'm not a doctor. So this was how I started, this center in Kaduna. And this was my reason for doing so.
Right, thank you. So what are the challenges you face now? What is very difficult about running that center?
there are a lot of difficulties. And I think even the awareness, about addiction, the first speaker has said, a lot of things that, resonate with me. There is a misunderstanding about what addiction is. It is, I understand now that it is a mental condition. But once we say something, it's to do with the brain, there's a lot of stigma, there's a lot of denial. So before, we even get people coming to us, it has gotten to a very bad situation. And when they do come to us, quite a bit of the time, there's nothing that we can do. So we refer them to hospital first of all, and then for rehabilitation. And when they come out, then, we step in to continue with, relapse prevention. So the denial, the stigma is one of the greatest challenges, even to admit that there's a problem and that you are willing to get help, for that problem. So this is what I see as one of the major things that is, causing roadblocks in what it is that we're trying to do. I believe, there's a need for a lot of, awareness, not only for the addicts themselves, but even for families and friends in terms of how they can support. I understand what is happening because I was an angry outsider. I was just, always blaming. I felt, this person could control what they're doing, and they should know, not to do what is harmful to them. But, as I understood a bit more, and I'm still on this journey and understanding even much more, I realized that, we need to understand that this is see it that. Because if you have a problem with any of your organs, you don't mind seeing a heart specialist for your heart problem. You don't mind seeing a kidney or liver specialist. But when we say it has something to do with the brain, there's a stigma attached to it. Nobody, wants to see a psychiatrist. I mean, I'm sorry, to say this to the psychiatrist, but people just feel, no, I shouldn't, because if I do, then that means, it is certifying that, I am mad or there's something wrong. So we need to be able to educate more about what this is, and we need to be able to speak up about it, because there's a lot of there's a conspiracy of silence. It was done with HIV at the time. Now, if we are able to bring it out and speak out, speak about it in the open and get the right information, and all those myths that are out there for us, I think it will go along in helping, supporting the people that are going through this and their families as well.
So yes, thank you very much for that, really. You mentioned about the stigma and also just making people more aware of the situation. It's so important. So the next person is Abdullah Baikira. So I don't know, you're here with us. So he's a protection officer at the National Commission for Refugees, Migrants, and Internally Displaced Persons. So he's here today, really. I'm really grateful for you to come here, and he's going to tell us about his experience with substance abuse. So what aspects have been difficult? Is it the treatment? Is it the stigma? Is it the reintegration? So, we'd like to hear from you.
Well, I'd say hello, everyone. As she rightly said, I'm Abdullah Baikira. I work with the National Commission for Refugees, Migrants, and Internally Displaced Persons. I personally would like to share my experience with drugs and substance abuse generally. I basically was an addict. So what I'd like to say is, well, my encounter with drugs here in Nigeria started at a very, very young age, pretty much barely 14. Started with cigarettes, which I got from my father's ashtrays and people around me and brothers and all of that. Well, my role, I at first I was in denial, of course, as it was common with everyone, as I came to understand later, much later. Personally, I did a lot of drugs, which too many to start mentioning now, but the journey hasn't been quite easy. But I'm glad I'm where I am now, with the help of people like Halima Shehurimi and Hajia Hadiza Aliko. I was at a seminar some 7-8 years, if I'm right, in Kaduna with Hajia Saidia and Hajia Hadiza Aliko. And I think that was the turning point in my life. I got to an all-time low in my life. I was in serious denial, actually. I never believed doing drugs or anything of the nature was wrong. At first, I didn't even accept I was even doing anything wrong. Sorry, I hope you can hear me. The neighbors decided to throw a party.
I can hear. We can all hear, I think.
Yeah, so it started with experimentation. So, when you see, as we rightly say here, every child wants to be a prototype of his father. I grew up with a smoking father, whom later quit anyways, but that caught my attention. That drew me into doing drugs, marijuana, so many drugs, actually. The most difficult aspect of it was trying to wean myself off the drugs without going to rehab. I've actually never been to any rehab. I did this all by myself with the support of family. Great thanks to Hajia Saidia Rimi. Yeah. The thing with the society now, what I've come to notice is now I do a lot of counseling for my persons of concern, considering where I work. But I mostly deal with refugees, migrants, and IDPs, but basically mostly refugees. You see, now it's the thing is, the difficulty we're facing with refugees is that you have to let them into the country, because Nigeria is signatory to a lot of treaties. So we have to let them into the country, and in the process of them coming, many habits come along with so many of these people from other people. That is talking about refugees now, talking about my workplace and substance abuse. But amongst the youth now, one of the basic problems I've noticed is the denial aspect and the availability of those drugs on the streets. So what I'll contribute now is staying away from drugs. I believe is, you have to have the mindset, you have to be willing to quit doing this before you can quit. Because I kept going in and out, relapse, back and forth, before I finally think I'm out of it now. Thank you.
Thank you very much. Thank you for sharing your personal experience. Yeah. So the main issues really is the denial, isn't it, at
yes,
first?
Yes.
Yeah.
Yes.
Okay. And luckily you were able to get through it with the help of, as you mentioned, Hajia Saidia, who I know very well. And she actually connected me with you. Yeah. So they've done a good thing.
Yes.
And also Hadiza. Yeah. And they're both non-medical, but because of the frustration they had, they, just picked this up to, help family members and other people around. So thank you very much. So Dr. Isioma Nwokolo, she's a consultant psychiatrist.
Sure.
She's working for the NHS. She's a teacher, she's a mentor, she's a life coach, she's an author. She's also a CEO of, is it FREO, is it FREO website, correct me, which will be live soon, with lots of, they'll be offering lots of therapy and activities will be available once the website is on. They seek to prevent, treat, and improve mental and physical health well-being. And she also has got experience actually having her own private hospital in Nigeria. I think it's still existing before she moved to the UK. So it's really good to have her because, she's experienced being a psychiatrist in Nigeria and also in the UK. And she's also a member of the All Black Psychiatrists in the UK. So she'll be telling us today, how does addiction in Nigerian youths differ from the rest of the world? And just tell us your experience with, only having your own private hospital over there and coming here and working for the NHS. Thank you.
Thank you very much, Sadia. Like everyone who has started talking here today, I want to commiserate with the country, with Nigeria, with the armed forces, with the president, for the very sad and tragic accident, air crash, where we lost a lot of armed army officers, including the Chief of Army Staff. I worked myself for about 4 years with the Air Force and the Army as a civilian many years ago. So I just want to commiserate with everyone. I also want to thank Dr. Sadia for inviting me to speak in this very good seminar with lots of very experienced and honored people. So thank you for giving me this opportunity. So my journey with psychiatry started in 1992 in Nigeria, in Lagos. And during that time, in the 4 years I did my training, which was in Yaba Psychiatric Hospital, I came across quite a number of especially young people who had schizophrenia and other psychiatric illnesses, but a number of them had a comorbidity with drug substance misuse. And that was what kind of triggered my interest in psychiatry, because I saw a lot of people whose lives were wasted or wasting at the time, and a lot of families who were grieved by the fact that their children were involved in substance misuse. I belonged to a church at the time, and so in 1996, I helped to set up something called Hebron House, which was one of the first, in fact, the first of its kind in Nigeria. And it was a combined formal approach to treating substance misuse and addiction with religious, undertones. I then, within the same year, 1996, started my own, which was called Prince Rehabs. And I also started a non-governmental organization called Liberation International. And Liberation International, the main focus of it was to help street boys, area boys, and prostitutes who were involved in substance misuse. And what I was doing, I was part of the Drug Demand Reduction Association. I was the assistant secretary. And what I was doing was creating awareness about substance misuse. I was working in conjunction with the National Drug Law Enforcement Agency and the NDLEA, which is the National Drug Law, United, the UNDCP, United Drug Control Program, and also worked with the Refugee Program to create awareness. And I was doing I found some unique ways of actually reaching the area boys, because people were frightened of the area boys at the time. A lot of them were involved in crime, and they lived in some pretty dodgy, high-risk areas. And I found myself with my team going there, and I found a way to bring them out, and so they could listen. So I created avenues like football. So I would get the groups of area boys and form them into two football teams, and they would play each other. And I got T-shirts and educational materials from the NDLEA and the UNDCP, and we would they would wear those T-shirts with say no to drugs and so on and so forth. I also found music. I found that they enjoyed music like everyone else, so I would invite some well-known musicians in Lagos at the time, and they would come and play. And sometimes we would have 3-day kind of events where we would have music, they would play the football, there would be food, free food, and drinks for everyone. And also I write plays. So I would write, I've had a number of plays I wrote about substance misuse and so on, which we would show to the young people. And the other thing I did, because I had my own drug treatment and rehabilitation center, was to offer them free treatment. So if they wanted to be treated and they wanted rehabilitation, we would offer them that opportunity. And once we'd done the treatment and the rehabilitation, we had the vocational area of that hospital, which would give them the chance to go back to school, to learn a trade, and so many things. So yeah, it was a great experience. I also, another part of it was going around schools. So we're going around schools and educating the youths about substance misuse and the dangers, etc. And of course, at the time, HIV was quite prevalent. So we talked a lot about HIV as well.
Yeah, that's quite interesting. So really it's engaging the youths and, you know, providing activities for them. And as we know, our youths are quite idle now, you know, a lot of them in Nigeria. So I guess that was what helped you when you had your private hospital also, just to engage them with different activities. Yeah. Okay, so we'll go back to Mr. Isagachi. I don't know if he's here already. So just briefly, just tell us about your journey, you know, with substance abuse and how you recovered.
Okay. My name is Isa Sanigichi. I'm a recovering addict with 13 or 14 years clean time. I think I started using at secondary school. I almost use almost all the drugs. Can you hear me?
Yes.
Can you hear me?
Yes.
Okay. I think I almost all the drugs. I can't remember what I took. Why I decided to go that I don't get high anymore. So I was in denial. When I reached that stage, we call it rock bottom. I decided to check into recovery house by myself. So I went to recovery in Cairo. I stayed for like 6 months. After I got clean, they gave me a work as a supervisor at the recovery home in Cairo. And I stayed in Cairo. I went to school. I got international license. I'm a certified therapist and a substance abuse counselor. And I've been clean for more than 14 years. What I do is I always try to tell people that you have to come out of denial. You have to pray a lot so that people can understand that people can get clean. Doctors always say addiction is a chronic relapsing disease, but people relapse, but there are signs that shows if you want to relapse. So what I do on my own is I always wake up and pray and not use again. That's all.
Thank you very much. Thank you. Yes, we can hear you. Thank you very much, yeah, for sharing your experience. So the reason you went to Cairo, is it because there was no center in Nigeria to look, you know, for you to get the treatment? Why did you go?
Really, why I went to Cairo is because, you know, in active addiction, people who are in addiction are very, very manipulative. I'm the kind of person that I was very, very deep into addiction. I can manipulate the doctors. I can manipulate the psychiatrists. I can pretend. But really, why I went to Cairo is because I want to change environment so that I can keep away from people we call high risk situation, using friends, people who use. And at the time I left Nigeria, there were not so many recovery centers like now. And many people were in denial. That's why I traveled out.
Okay. Thank you very much.
Okay.
Thank you for sharing your experience with us. Thank you. So the next person I wanted to ask question, I don't know if he's here, Dr. Beda or Meza Beda. Dr. Daniel Ogolote. He is a child and adolescent psychiatrist in the UK, and he's also a member of All Black Psychiatrists UK. So Dr. Ogolote, can you tell us about your service and work with young people with addictions and drugs in the UK? Thank you.
And thank you very much, Sadia, for organizing this program. I think you are involved in a very laudable, initiative and doing a great job. And thank you for the invitation to share on this forum today. I also want to express my condolences and sad felt condolences to the Nigerian army and the government as a whole, for the very sad incident involving the army officers as well. So I'm a consultant child psychiatrist and also an adolescent addiction psychiatrist. And I thought for today, I'll give you just an overview of my service and how we work. My service is called the Drugs and Alcohol Mental Health Service for Young People. And the way services are structured within Northern Ireland, where I live, is that, or child and adolescent mental health services are structured, is such that we have various, it's called a step care approach. So there are various steps. And the general, CAMS or child adolescent mental health service delivery is at a level of step 2, which is at the lower end of the spectrum. Then we have the step 3, and step 3 is where we have the multidisciplinary teams, which involves psychiatrists, psychologists, social workers, all working with presentation of young people, or with young people who are presented with mental health difficulties. And then we have the addictions, service, and the addiction service within child adolescent mental health service is the next step, which is the step 4. And that is dealing with, the high end of the spectrum. I would say that the way services are organized within within Northern Ireland or within the UK for young people is such that the bulk of people who are presenting with general symptoms of addiction, just using substances in a very chaotic fashion, are dealt with by the voluntary agencies and voluntary organizations. My service is at the end where people are using substances having additional impact on them. So substance use having mental health problems. So we call it a dual diagnosis service. So addictions with mental health, and work is that we work collaboratively with the voluntary sector and also social services and also justice services in providing and care and treatment for young people with addictions. In terms of the young people that I deal with, I'll give you just a gist of the profile of my young people who present for addictions. And if you take all young people presenting for addictions, these are people who would have been exposed to early life adversities, people from very difficult background, broken homes, early life exposure to trauma, family difficulties, people who come, the majority of people come from deprived communities within our inner city services. These are people with poor social support and early life, peer influences. What I want to say is that a lot of young people experiment with drugs very early in life, but only a minority of young people go on to develop an addictions problem. So the question we want to ask is, why is it that about 50% or so get exposed to drugs, experiment with drugs, but about 90% of people will stop using drugs, and only about 5 to 10% go on to develop an addictions problem. So the question is, we need to ask is, why do people get addicted? And these are the people who, on trying the drug for the first time, realize that the drug does something for them, or it takes care of something. And therefore, in my dual diagnosis service, our focus is looking at, the substance use is a symptom of underlying difficulties, and some of the things that I've highlighted below, and that the drugs are providing a certain, effect, either there are only a few people who love the high of addictions and continue to use. But majority of people deals with, or the drugs help them to deal with underlying mood problems, social anxiety problems, trauma memories. Some use it to help them to fit into the system that, to cope with associated difficulties. And so knowing that addiction is a symptom, we go beyond the drugs to try to understand what is maintaining the drug use. And therefore, in the service that I use, we have certain key principles or philosophies that we work with. So one, with all young people, we deem it that young people who are abusing drugs don't see it as a problem. And therefore, this is more of a problem of society, as it were. And therefore, what we do is we try to go beyond the drugs to try and engage with these young people. We try to go, get to know them. We do everything to establish a relationship with them, because people giving up drugs depends on the relationship that we form with them. And so we go beyond, the drug itself. It's important to establish what's called therapeutic relationship with these young people. And therefore, our approach to treatment is very strength-based. It is supportive. It is non-judgmental. We try to empower the young people. There's a lot of empathy in what we do. And therefore, our approach to treatment is then, programmed into three main phases. The first phase, when we meet these young people, after taking the history, we think that you are present for addictions, is that we do everything to help to stabilize you. And then once we stabilize you, we then motivate you, to get into therapy. And then the therapy then goes on to treatment. Now, these three phases of stabilize, motivate, and treat are not discrete. They kind of flow freely into each other. The stabilization phase, we look at, because it's a dual diagnosis service, we try to diagnose if there's a mood problem, there are sleep problems, there is withdrawal symptoms, there are comorbid symptoms of trauma, anxiety, or psychotic symptoms. We try to use medications to help to stabilize this. And then once the mood and those things are stabilized, we then go on to look at, therapy, which is psychological therapy for the management of the young people. And it's important that, and I work with a group of people who are trained in all modalities of therapies, including, cognitive behavior therapy, family therapy, attachment and trauma therapy. And also we work with families as well. So in dealing with young people, it's important not to just focus on the young people, but to focus on the systems around them to help stabilize the system, to then give them, the strength to be able to then deal with the difficulties they present with. We also work collaborative with the voluntary sector, agencies. We work with social services. We work with the law enforcement agencies, that the juvenile justice systems. So wherever these young people are, our services are made such that we work collaboratively to kind of provide the input and the support and stability that then goes on to help the young people, come off the drugs. As it's been said, it is a journey, and people, is dipping in and out. But the key focus is never giving up on the young people, hanging on to them, supporting them, journeying with them, and making them not feel isolated. And if they're isolated, we provide a network of support that is needed. So broadly, this is how my service is structured and how we provide the services. And I'm going to stop here. If there are any specific questions, I'll be able to then kind of clarify or answer. Thank you.
Oh, thank you, Dr. Daniel. That was fantastic. I like the mobilize, stabilize, and treat, is what you said. Yes, that's quite important. And you made a really key point about not giving up. So sometimes, people might just feel, they would give up, but not giving up on the young, adolescent with drug addiction is very important. So I'm going to go back to Professor Sheikh. I have a question before. What are the challenges that psychiatrists are facing in Nigeria? And what is currently being done to overcome these challenges? Is Prof there?
Well, yes, I'm here.
Yeah.
Thank you very much. The challenges are quite enormous, and you've had the previous It's talking about issue of stigma, people not wanting to go for neuropsychiatrist consultation, people in denial, not wanting to agree that this is the kind of condition they have, treating substance use related problems as a lifestyle problem. There is a lot of challenges, but if you want to deal with mental health issues, first, you need to develop a framework that will ensure good governance regarding mental health administration and practice. And in this country, we have a mental health service delivery policy, which was revised in 2013. Yours, obedient servant, happened to be one of those who revised the mental health service delivery policy for Nigeria in 2013. That policy is due for revision, which has not been done, and it needs to be supported by a strategic plan. And that policy will deal with the issue of taking care of the mentally, of the people with substance use disorders, just like the immediate previous speaker, doctor said, how they deal with it in Ireland. If we have a good mental service delivery policy that encompass dealing with substance use disorder and have a very good, achievable strategic plan to match it. The next thing is the law for mental health. We need legislation for mental health that will also encompass dealing with substance use disorders. It will shock you to hear that we are still in this country using the Lunacy Act of 1916 that we inherited from British colonial masters and became laws of Nigeria in 1959 when other regional governments adapted it. We have been over 30 years, about 35 years now, struggling to have a modern, compassionate, effective mental health legislation for Nigeria. Presently, there is a mental health bill that is sitting in the National Assembly. It has gone through 3 readings at the Senate chambers, and it's the House of Representatives for concurrence. I would want to employ everybody here to use whatever connection you have to push the Federal House of Representatives to push this law to the presidency to sign. This law will completely change the face of mental health in Nigeria and also deal with the issues of substance use disorder. Substance use disorder is a cankerworm that is threatening the entire survival of this country. So if we are able to get the mental health bill passed into law, I think it will go a long way in addressing the issue of substance use disorder in this country. We have a Senator Ibrahim Oluri, who has taken interest in this bill, as taken it as a personal responsibility to see that this bill becomes a law. We also have a honorable member of House of Representatives that is the chairman of the health committee that is also passionate about it. But I want all of us, the stakeholders, to push it to see that this bill comes into law. We also have issues of funding for mental health and substance use in this country. UNODC is doing a lot for substance use in Nigeria today. But we need to have a political will. Our own country leadership needs to have a political will that will address the issue of substance use disorder in Nigeria. Look at the various levels of prevention, primary prevention, secondary and tertiary prevention, to have a program that will prevent the use of substances, that will address those who have it and prevent complications, that will rehabilitate those who have suffered from it. So we need political will and commitment by our leadership to provide funds, direct budgetary allocation to deal with substance use disorder in Nigeria, and also to integrate substance use disorder at all levels of healthcare delivery in this country, at primary healthcare, secondary healthcare facilities, private clinics, everywhere you go. Integrating this integration approach is another way of funding substance use disorder. It will be part of every service that we are providing. So these are challenges that I believe we can overcome. I don't want to just talk about challenges in abstract. I want to talk about challenges that we can deal with And I believe taking these steps, we'll be able to deal with these challenges. And then there is need for mass education, grassroots. We need to engage grassroots non-governmental organizations. We have some grassroots non-governmental, like Mandate Health in Abuja, a lot of them. They are there, we are working with them to go to the grassroots and speak the language that the local people will understand regarding substance use disorder in Nigeria. It is not something for the elites alone. We need to speak the language that the local people will understand to be able to deal with this. I cannot exhaust these issues and how we can deal with them. I'm sure other, panelists have things to say regarding to this. Thank you very much.
Thank you very much, Prof. So you've mentioned about the mental health legislation, involving grassroots organizations, and funding is needed. Thank you very much. Okay, so I'll go to Dr. Abaji. You're based in Canada. Obviously, you're a very patriotic Nigerian. So what do you think, people like us in diaspora can do to improve the current situation? That's one question. And if we remain as we are now, what are the consequences of doing nothing? I know Prof has mentioned just a bit of that. And are there any international standards for the treatment of drug abuse? Sorry, I've bombarded you with 3 questions all at once. So you can choose.
Thank you very much, Sadia, for having us, to contribute based on what we know and our experiences, especially in diaspora. And I would also like to join the rest of the panelists in sending our condolences to Nigerians who have lost not just what we've lost in the last 3 days or so, but almost every day you wake up with the bad news. It's so sad, but I'm also glad that we are coming together to address some of the pertinent issues that has been really eating into the fabric of our society, which is addiction. So you've asked lots of questions, so probably let me just start with the simplest one. The simplest one is there is no one solution fits all in terms of standard of care for individuals who have suffered or who are suffering from substance use disorder. It should be customized to local needs. It should look at the pattern of use in those communities, because even in Nigeria, if you look at, there is regional variation in terms of substance use. What is predominantly used in the north may not be what is predominantly being used in the south of the country. So, but the common theme is there is a problem, and as Dr. Tayo, Professor Tayo said, this is eating into the strength of our nation, which is the youth. It was very alarming for me to hear that almost 80% of those who are suffering within an active age group, which is the youth. So if we continue like this, I don't know, it's going to be really very difficult. Having said that, the WHO, which is the World Health Organization, and Nigeria is a member state, in conjunction with the United Nations Office on Drugs and Crimes, they have an international standard of care for substance use. And this international standard of care is intended to help each member state develop an effective, evidence-based healthcare delivery system that would address the substance use disorder within their locality. And these standards are meant actually to help us to develop our own policy, to look at how we can fund. As you've said, funding is one of the main issues. So it's look at how we would fund, how we would deliver those services, how we will monitor them, how we'll evaluate effectiveness of those services. And but the key goal here is it should be available, it should be affordable, it should be evidence-based, and it should be diverse. We here in Canada, for instance, we really don't ignore culture. And as the rest of the speakers have said cultural context in an effective treatment for substance use is very important. In Canada, we have a large number of community who use substances, which is the Aboriginal nations or the First Nations. And the elders within those communities play an important role in the delivery of services. If you say that you're going to just address it without them, you're certain to fail. So, having that into the Nigerian context is the same. If you look historically, the church had played an important role in treatment of substance use. The 12-step approach for treatment of substance use, started from the church. So there are so many things that you need to incorporate in order for it to be effective. Now, come back to what Dr. Tayo said in terms of at what level should we intervene. He mentioned it beautifully well, that at the primary, secondary, tertiary, and quaternary level. At the primary level is identification, early intervention. That should be the case. But unfortunately, maybe those panelists who are working at home would be able to tell us more, but it is difficult. Even here, we have in the US, for instance, there are over 30 million Americans who are active abusers of substances. Unfortunately, only 10% of them receive the appropriate care. So I can imagine what happens in Nigeria. So an early identification and intervention means when somebody presents with a single abuse or an intoxication that has not yet gone on to develop a chronic abuse, so you need to identify and treat them immediately. But do we have the capacity to run a drug urine screen test, for instance, to, when they present to hospital for you to know? Is the government taking care of those social determinants of health at that level that will address issues that may propel a young adult to start using? So these are the things that we need to ask ourselves. For instance, now I was reading in a paper that actually was published in Lagos, one of the largest research that they've done in terms of youth, that 70% of those youths who use actually have not finished high school. They've not finished secondary school. So, which means there is a point at which we can actually target and address those issues. So, and then of course, with the Lunacy Act that Professor Tayo had mentioned, we are hopeful that our legislatures will really step on and do something immediately. The federal government needs to actually come with a policy framework that would support that. It's not just to have the Mental Health Act functioning. There has to be a policy framework that would support it to function. And there has to be a form of training that the addiction counselors, anybody who is working with individuals with substance abuse, they would understand that this is part of a continuum of care. That when you have somebody who has substance use disorder, you don't see him singly as just having some substance use disorder. Substance use disorder is generally a symptom of so many things that is happening. So you need to address those continuum of problems that are embedded within the individual. And of course, the people with substance use disorder deserve the same level of care that anybody with chronic physical health gets, because this is a serious disorder. So, I mean, I know that we have so many things that we're going to talk about, but these are the things that I would like us to approach. A lot of the speakers have mentioned, so many important points, and I hope that we will take them and share them with those mental health advocates that are within the legislations, kind of to share with them and how best we can push things together.
Thank you very much, Dr. Abaji. That was really quite a good summary, I would say. I don't need to summarize anything. You've covered everything. So I was hoping that we would take just a few minutes break, and then when we come back, you're actually going to be the moderator, and everybody would have an opportunity to say something or to ask questions. So it will be more an interactive session. So please, let's just take maybe 2 minutes rather than 5 minutes. Just if you want a drink or something, you know, then we start again. So this is 1707. So we start at 1709, something like that.
To Professor Tayo, if you're still there. Okay.
Yes,
so,
Prof, I'm here with you, Prof.
So it's good to have you. It's really good to have you. I've read a lot of your work. You probably would not remember, but we've met many years ago in Kaduna when I was doing my housemanship. That's really so many years ago. And at that time, you've served as a mentor to so many of us who end up going into the field of psychiatry. And I'm sure, you know, a lot of other psychiatrists who have worked in ABU Kaduna. I did my training in Maiduguri, but I did my housemanship and subsequently briefly worked in Kaduna before leaving. So, so you are loaded with so much experience that we would like to tap into it. Now, with your role as in the college, where you supervise training both at students level as well as the postgraduate level. There are not many, I don't know, you probably would speak to that. There are not many people who have had a specialized training in addiction in Nigeria. But the question is, do we have the adequate training, not just as doctors, but also as therapists, any other person who works with individuals suffering from addiction use disorder? Do we have the adequate training and capacity to meet these challenges that you've mentioned?
Thank you very much, Prof. And thank you for your kind words. I'm profoundly humbled. Thank you. Well, in terms of training for substance abuse, if we look at levels, just like you said earlier, if we look at various levels of the cadre that are involved in the care of people with substance use disorder, we don't have enough psychiatrists in Nigeria. We have just about 300 psychiatrists. Today, I'm the president of the association, so I know I can count the numbers. I know everybody one-on-one. We have very few. We have about one psychiatrist to probably 100 to 1 million Nigeria, or even more than that. So that's extremely, it's extremely low to extreme. So also we lack the number that we need for clinical psychologists who are very, very key in management of substance use disorder. Worldwide, we all know that they're very low, the clinical psychologists. We also have low number of psychiatric nurses and those who actually take interest in substance use management. However, we have to understand that there is need for task shifting to people who are not necessarily as highly trained like the psychiatrist or the clinical psychologist. And that is what we are looking at. And our service delivery mental health policy for Nigeria, and what the mental health bill is also gearing at, is this integration and task shifting to shift the skill for mental, substance use, this care to people who are not necessarily highly skilled, like the psychiatrists. And UNODC is really coming into this. They've done a lot by using people like us for task shifting, to go to the community level, to go to even lay people that don't even have anything to do with medical practice, to be able to provide motivational counseling, to be able to identify within the community those that have issues with drug in the early phases, and be able to do a referral to where they will be able to get help, to be able to do advocacy, to talk to the community people, to talk to people, train them on advocacy technique, on how to let people know and convince them that this is a problem and this is how to go about it. We cannot just stop at the level of highly skilled, personnel. So this is the way I see it. While we are opening the doors to train more people who will be highly skilled, let government support this training by various postgraduate medical colleges. We also need some task sharing and also task shifting. I think for our country, and especially low and medium income countries in the world, task shifting is key to dealing with substance use disorders.
Absolutely. I mean, this is something that is not just peculiar to Nigeria, but again, in any environment that we lack adequate resources, task shifting is an important aspect or strategy of getting people ready, to address issues. There's a question that came specifically to you from the chat room, and it's coming from a physician who asks a very important question. And again, this are some of the things that I have come across myself here among some of our colleagues who use drugs. These are physicians who are struggling with addiction. Is there any a mechanism for support for them through any of those professional bodies, either the association of the NMA or any other professional association? Because it can be very difficult. You find that to come out, to even be brave enough to say that I have a problem, you perhaps maybe feel threatened that what's going to happen to your job, what's going to happen to your license if you did. So, but for those who want to come out and seek help, what are the system in place that are there to support them?
Thank you very much. This is a very, very important and valid question. I have personally managed my colleagues who have substance use problem, but we still dealing with denial. There is a lot of denial seated within even doctors and health professionals who are under the burden of substance use disorders. Yes, and unfortunately, it's also potentially fatal. I have lost colleagues to substance use disorders, doctors, specialist doctors, nurses to substance use disorder. Our major problem is for them to come out. Our major problem is for them to agree to come in for treatment. We have given them a lot of confidentiality. I've managed a lot. I have seen a lot who have recovered, but I've also seen those who unfortunately died as a result of substance use. They break, they relapse, they run away, they don't come back, and one day you hear of their obituary. Our major challenge is with our colleagues who are under this burden. We bring this matter up during NMA meetings. Even our colleagues don't seem to understand. They still carry this misconception about substance use disorder. Even among doctors, they still see substance use disorder as a lifestyle problem. They even talk to some of our patients that finally end up in rehab home that a doctor told me that this is not an illness. So it is something we are still struggling to cope with. But we do have special, arrangements for our colleagues who have it. The pressure on doctors, the pressure on nurses is very high. And if you look at it, Prof, worldwide, suicide rates among healthcare professionals is among the highest among various professional groups in the world.
Absolutely.
And Nigeria is not an exception. And what can
Absolutely.
push you to suicide can push you to substance use disorder. So the pressure is high on healthcare workers, and we have special arrangements to look after them if we are able to recognize them, if they are able to come out.
Thank you very much.
Confidentiality is preserved. Yes, sir.
Thank you very much. Because I personally have lost a very close friend in Nigeria to suicide who had suffered from substance use disorder, and he, in fact, was a physician. Thank you so much for sharing your thoughts on that. Dr. Isioma, thank you very much, for all that you've done. You have you've started at the time when so many people were not actually into what you have done. I mean, you talk about nearly you engaging the youth that we are now trying to do in the 21st century. For almost those decades, you have done your best, and I would really want to say thank you for that. But my question to you is, if you were to go back home now, if you were to go back home with all the things that you've learned in terms of addictions and mental health, both in Nigeria as well as in the UK. So if you were to go back home and start, what are the things that you would do different that would help you succeed even more with all the things that you've learned?
Thank you very much, Prof, for that question. What I think I would do differently would be to try and, like the president of the Psychiatric Association, try and seek more formal legislature that will actually mean that there are more services available, formal services, because like I said, a lot of what was available at the time was charity, NGO. The government at the time and the main psychiatric hospitals were not really doing a lot to help or recognize the people who are suffering from this very debilitating disorder. So I think I would probably try and help with pushing, that legislation. I think I would network more. We did have an association at the time called the Drug Demand Reduction, and we were all trying our best to work together as a team and work with the United Nations and so on. I think I have more knowledge now, certainly having worked in Nigeria and having worked abroad, in the various methods of treatment. One thing that I've never really been, someone supportive of is the methadone replacement therapy. So I've always actually preferred the fact that in Nigeria, people were quite willing to not exchange one substance for the other, but they were quite willing to go through the treatment process and stop taking the drugs rather than going on to the methadone replacement, which is, again, to me, another form of addiction. So I think we had that, that was positive in Nigeria as opposed to here. In the UK, we have the same problem. I think the government here has taken away money from addiction services. So it's very rare that you would admit a patient to a psychiatric hospital in the UK just because they have an addiction problem.
Great,
Usually
thank you.
They would have to come in with either schizophrenia, bipolar, or something more severe, and then have a comorbidity that will be treated. Otherwise, if they have an addiction and they need a detox or anything like that, they would be asked to go to other services, which, again, a number of them are charity. So if I came back to Nigeria, I think it would be to establish formal government-supported units, treatment units, to make it available for people right at the grassroots, to educate or to encourage education right at the grassroots level. So you were right, the age of when people start tends to be about 14, 15. I found that in my practice. So it would be to go to people right down from primary school, secondary school, to start to educate them about the dangers and what to do when people are under stress. So not to go to drugs, but to, you know, find alternative methods of engaging themselves.
Thank you. Thank you very much. I think you've nailed it there. You know, go back to where it starts and start addressing these issues. And if I may also add, maybe to add into our school curriculum, the vices of substance use, so that even young adults who are not using, they would understand what are those challenges or consequences of substance use. So I'm going to ask Dr. Baida, who, are you there, Dr. Baida? Or Baida?
Good evening, Prof. Hi.
All right. How are you doing? Thank you.
I'm fine, thank you.
Yes. So I have a question for you, and you've addressed so many important things, you know, in terms of addiction and mental health. And one of the things that I've seen in the chat room that is kind of so common to some of the things that you've specifically said, but some people need you to share some more light into some of the complications of drug use that young adults would face, especially in Nigeria. So, what are those complications that you would share with us?
Thank you, Prof. I'm the head of the emergency psychiatry at the Federal Neuropsychiatric Hospital in Kaduna. Kaduna is a metropolitan city, a large city, and the hospital is sort of centrally located in the city. And because of that, we get a lot of patients coming in with drug use and complications of drug use. You know, I mean, from our own data, we've seen that this trend has been increasing over the years, and it's quite horrifying. We see children as young as 7 come down with tramadol overdose. Complications like seizure is quite common. You know, it's not about, if you look at the pattern of use, most of them come down with tramadol, alcohol, cigarette, or like Dr. Isomoda was talking about comorbidity. What we see, it's a lot of cases with intoxication. So most times when I walk into the emergency ward, out of every 10 young men there, before I even start my ward rounds, I'm almost certain that 8 of them have a drug use associated with their problem. So it's quite, I would say from my own, where I stand, is an epidemic, because we see it every day, and it's quite troubling.
So what are the common substance of abuse that present to emergency room? That
from my experience, alcohol, cannabis, we're beginning to see the tramadol, then the codeine associated groups, usually in form of cough syrup. So these are the common substances we tend to see at the emergency. Complications of this we tend to see at the emergency ward.
Yeah. So when you see them, you know, this is the question that things that a lot of people have spoken about: continuum of care. You know, what next? So they come in with intoxication or withdrawal to the emergency room.
Yes.
And you've detoxed them, you've treated them acutely, and
yes.
you're discharging them back into the community. What do you discharge them for?
Okay, so this is the situation. Now, when they come into the emergency, as you said, what we do basically is detoxification. But while they are in the emergency ward, you know, we have a rehabilitation center in the psychiatric hospital. It runs as a semi-independent unit It has its own policies, its own rules. So, but while at the emergency center, we detoxify them and stabilize them. And while they are there, we prepare them for the rehab ward. Okay. Now, but the challenge we tend to see most times is by the time they are stabilized, getting them to proceed to the rehab ward, we have a number of challenges. One will be finance. It costs money and somebody has to pay for it. So if the relations are not ready to pay because they feel, well, this guy just took this drug and he's the cause of his problem. So they don't understand it like, okay, this is an illness. They be, well, he's the cause of his problem. This is a spiritual attack. He's a disgrace to the family. They blame him for the problem. So most times they are not ready to foot the bill, either because they feel he's responsible for the problem or because they don't just have the money. So these are some of the problems. So it's not about just getting a motivated patient to move to the rehab ward. There are other social problems that can be quite difficult to handle in trying to get these patients to get the treatment that they actually deserve, they need.
Thank you very much. Thank you. I mean, you're very right. The finance, to pay for things in back at home, not just even for other things that people accept, other medical conditions that people accept can be challenging, left alone addiction. But one important thing that I may add to what you've said is the social cost of illicit drug abuse is huge to any community. In fact, the UNODC in 2016, they published a data where they said that nearly 1.7% of a country's GDP can be consumed by substance abuse. So it is a huge thing. Therefore, providing an effective treatment and care services to these people that need it is actually an investment into any community. So it's very important that you've mentioned, and thank you very much. So Daniel.
So maybe we'll give two people to speak and then two questions and then we can
sure, absolutely. Yeah. This is getting too much interesting. That's
yes,
why
it is.
Carried away. So,
hello.
Yes, hello, yes. Anthony. Can you introduce yourself and then ask your question, please? Thank you.
Okay, I'm Dr. Anthony. I'm a consultant psychiatrist in the United Kingdom. I've been practicing for about 15 years now. I'm originally graduated from the University of Benin, migrated to the UK 2003. I'm a dual qualified psychiatrist, which means that I would do a certificate of completion of training, which means I can work with general adults and older adults. I have a good experience of addiction psychiatry. I've worked both in a rehab setting and also worked in an outpatient setting where you just see patients and they go home. So I have a good feel of both sides of addiction psychiatry. I'm not very good with names. The prof, the chairperson for the Nigerian Psychiatric Association.
Yeah, Professor Taiwo.
Yes, sorry, Professor Taiwo. Yeah, as I liked it, there are a lot of drawbacks, a lot of difficulties stemming right from manpower, and I don't know how that will be addressed. Maybe my little suggestion would be in that aspect would be perhaps looking at trying to see how people in diaspora, even if it's just a 1, 2 weeks, 3 weeks coming to Nigeria to just help out. I'm sure a lot of people will be very happy to even do it without being paid. I'll be more than happy to do that. I go to Benin every year and try to see what I can do for the psychiatric hospital there. If there is a program like that where people in diaspora can just, because we have a lot of psychiatrists in the UK. I would say bulk of the Nigerian medical community here, I would say maybe more than 50% will be psychiatrists.
Great.
And I'm sure a lot of people will be more than happy, even if it's, like I said, even if it's just 2 weeks, 3 weeks.
Yeah.
and you have a buck coming in like that, that's a lot of manpower that could be.
That is very true. That is very true, and thanks for your contribution. Because if you look at other specialties such as surgery, ophthalmology, they have diasporas going back home to contribute, through different NGOs. And in fact, in Canada alone, we have over 300 psychiatrists in Canada, so which is almost the same as the strength of workforce of psychiatrists based in Nigeria. So thank you very much for your contribution. Is there any other person who has his hands?
Yeah, there's Wale Lagundoye and Mark.
Yes.
Yeah.
Hi.
Just 2 minutes, please.
Yeah, thank you. I'm Olawale Lagundoye. I'm a addiction psychiatrist in the UK. I run a service where we have 3,000 patients in the city of Sheffield. I find it quite exciting that we're all coming together to discuss addictions and what I call the pandemic of addictions in Nigeria. This has been well overdue in terms of the need to begin to proactively work with our communities and specialists to address this issue of addictions in our community or society. And I want to second the previous respondent about the issue of how the diaspora can contribute towards building sustainable systems, because addiction is a complex phenomena that affects not only physical, social, and psychological well-being of the individual, and like you've mentioned earlier, has economic impacts that go beyond the immediate community. I do wonder how we can utilize technologies engage with our communities. Technology is what's helped us to join this conference, and I think there are some opportunities there. Everybody in Nigeria has 1 or 2 mobile phones, and that there is something about how can we utilize technology to engage with our society in helping to start to address these problems. Thank you.
Yeah, you're talking about telehealth, use of telehealth, that has so much expanded, especially during this period of COVID pandemic, to either use it for training our colleagues who are back home, discuss research opportunities, and also offer consultations. I think this is a good suggestions that you've made. Is there any other person who has his?
There is also Professor Adelekon Maruf. I don't know if you'll want to say something.
Yes, I would like to say something. Thank you very much for the opportunity. I got this notice just about an hour ago, and I felt quite excited that we are coming together to discuss this very important issue of addiction. It's a multifaceted problem. I was opportune in 2014 to write the drug control policy for the country as a consultant from the UK with another consultant from Italy for UNODC in Nigeria. I think we have another drug control policy in place now. And I've been asking the UNODC office in Lagos to update me with the current trends. And I think there was a recent report which was sent to me a couple of months ago. I've not had time to go through page by page, but I've been thoroughly educated today with the likes of Professor Sheikh Latif and our gentleman from Kaduna Emergency Department. The problem is really getting worse. And the musicians and the general public, they don't seem to understand the dangers. The musicians are actually glorifying drug abuse and, mixing chemicals and so on. Everybody knows that in Nigeria. Now, it wasn't there when I was doing my epidemiology studies in the 90s. You know, injecting drug use is also becoming a bigger problem. After we did the WHO injecting drug use study in year 2000. So it's a big problem. But there is poverty, there's so many things going on, and is the government really ready to spend money on addressing the problem? I think we need a bigger meeting that we can actually write like a memo from the meeting and send to the authorities, and whatever support we can give from here, we can give to the ministry. So it's a privilege to be here today. I want to congratulate the organizers, and I look forward to another time when we can look at, even if it's 20-minute presentations on current trends, on treatment methods, on obstacles to care, and so on. So thank you for giving me this opportunity to talk.
Thank you very much, Prof, for your insight into this trends of substance misuse in Nigeria, and also all the work that you've done, towards addressing these issues. I mean, you're very right in terms of the trends that have been changing. I mean, go back just even a decade ago, shisha joints have not been something that we've seen back in Nigeria, but now we've seen it. What we have been aware of is the use of cannabis, because Nigeria has the largest cultivation centers, farms of cannabis anywhere in Africa. So that is what we've known. That's how but things have changed. With this globalization, people now are seeing increased trends of use of opioids and others. Thank you very much for your insight. And also the suggestions that you've made, that a summary of this panel, to be made, and shared with policymakers. I think this would add strength to the work that our colleagues back home are doing. Thank you so much. So
we've got last person, Mark, has been raising his hands. Sorry,
Sure.
There's so many here.
Yeah.
Mark, do you want to say something?
Yes, please. I'll be brief. First of all, I have to join I have to congratulate everybody. It's lovely to meet Izzy again. She took me back to our days in Oxford. So hello, Izzy, to you and Dr. Adam and everybody. I have a question, or rather a request, and I'll be brief. As a crisis consultant psychiatrist, we see a lot of immigrants who, unfortunately, including Nigerians, cross over from Africa through to Libya. You can imagine the PTSD and all the issues. And there's also, unsurprisingly, substance misuse issues. Now, we need help in terms of familiarizing ourselves with the socio-cultural political issues. As you obviously know, establishing a therapeutic rapport is key. So my request is to have more networking, or at least training in this regard, because the ethnic minority of Nigerians, who are lovely, fantastic people, dare I say, who have special needs, including substance misuse, there seems to be this gap. So again, I would really welcome anybody to network with us, to really reach out into the cultural and religious elements, which I'm sure will help us of general rehabilitation for addiction. And once again, I congratulate you all for your initiative, and let's have more of this. Thank you.
Thank you very much. I mean, this is a good point you've spoken about. I know that especially in the UK, transcultural psychiatry is something that has been going on for quite a while. In fact, I think the main person who is leading transcultural psychiatry in the UK is Nigerian. I'm trying to remember his name. He was previously the chief examiner for the Royal College of Psychiatry in the UK. So thanks for your contribution. Sadia, is there any other person, or how do you want?
So two questions, Aisha, and then we can close.
All right, sure.
Okay, so I've got the first question from Zizi in the audience, who is talking about Muslim communities in northern Nigeria, and how there's a tendency to blame drug dependence on invisible enemies like, black magic, etc. And is there a way we can a way out of this problem? It's a big question, but that's what she was asking. And that goes to any of the panelists who feels that they can suggest any solutions to stop blaming drug dependency on black magic and look at it as an illness.
I can really just start. This is what we've spoken about earlier on, that you cannot ignore the influence of culture in a successful drug treatment program, and therefore to have to work with this spiritual leaders or whoever that believe that this is the devil or something like this that it has come up. There is a way of engaging them and understanding them, using that same culture to address the problem. Again, you coming here to Canada, where the elders, they call them the elders, for the Aboriginal or First Nation, they don't believe in the biological mechanism for drug use, that we know is biopsychosocial. So for you to kind of sit down and tell them that there is a disruption in pathways, neuronal pathways, that helps with reward centers or experience or memory and all those things, you're wasting your time. But if you came down to their level as to the social and psychological aspect, you would actually open a discussion where they would see that as a problem that requires help. So this is what I would suggest, because the ultimate goal is for that person to reduce use or go into more of less harmful use, or go into a total abstinence. That would be the ultimate goal. So, but I will leave that to some of our colleagues who are really practicing at home, who may have come in contact with this thing over and over again, to put a comment.
Thank you very much, Prof. You really said it very well. I just want us to understand that conditions that are poorly understood are usually blamed on spiritual attack, or somebody doing something, some demonic issues, including cancer, mental illness, substance abuse, most conditions that are poorly understood. Then conditions that are highly stigmatized, people find some shelter in blaming it on spirit or demon, and so at least you'll find something outside what you consider genetic or what you consider a social realm. You blame it on it. So these are very common. And I think one way, just like you said, is to have a very good community-based advocacy mobilization, to use community-based people, agencies, organizations, to educate people, to let them know the scientific basis of these things, and also how these conditions are treatable. If you go back, you look at the Arrow Village type of treatment of mental disorders adopted by Adeoye Lambo and his colleagues as far back as over 60 years ago. It's one of the advantages is to make relations, to see how people with mental health disorders are dealt with and how they recover, and be able to understand how treatment, modern treatment, can change the face of mental health disorders. So it's always good when people have conditions like this, don't just take them away from the families. Try to let the family be aware of the changes that occur leads to recovery. And that will further educate and entrench whatever you are advocating regarding to this condition. And there are so many other ways of dealing with it. I can't exhaust it here. Thank you, Prof.
So Aisha, last question, and then we can have a closing remark.
Okay, so one question that is from Anthony is, what is the interface between the police and mental health services, as statistics show that mental illness is high amongst prisoners? And again, that's to anybody who wishes to answer from the panel.
Well, there are studies, custodian studies that have shown that mental illnesses is highly represented among prisoners, either as a causative or as a consequence of crime. The mental illness could lead to criminal tendencies. Mental illness could also make you to be easily identified. You may not have the way to hide behind anything to shield yourself away from law enforcement agencies. And also prison custodian situations in Nigeria. This is so terrible that it leads to, at the end of the day, development of mental health disorder. So this is the way it goes. So it could lead you to crime, and custodial, services can also create mental health disorders. This is very high, and we have seen a lot of work that people have done in trying to justify these various reasoning for the overrepresentation of mental health disorders among prisoners.
I couldn't agree more with you, Prof, regarding that interface. And I think that speaks volumes of the need to even educate the law enforcement officers back home. Yeah. So educating them, that the pathway, if someone is arrested with drug or intoxicated or exhibiting evidence of crimes and misdemeanors, would be, if that person has an addiction problem, the police needs to know, where to take those individuals for help. And then, of course, where necessary, either to continue to offer the help or to prosecute, depends on the crime. I think this is very, very important. The forensic psychiatry in Nigeria, I don't know how far it has developed, where there is a connection between law and psychiatry, where you have forensic psychiatrists going into prisons to assess, treat, and then they work with the court in terms of disposition, where either to go to hospital, back into the community, along with some help, or even to be treated in acute care. So I know that we have long way to go. I can see from.
If you allow me, let me just add one thing.
Okay.
On issues of substance use disorder in Nigeria, it is very important, and that is what we want the mental health law, the new legislation, will address. Decriminalize the use of the substance. You can criminalize the commercials, activities related to the substance, but do not criminalize the user. The user has a problem, is sick. He needs compassionate, sympathetic care in a place where he will be able to recover, but not in the prison. Prison is not meant for someone who is under the substance use disorder. We need to look into that. That is why we are praying that let this bill be passed. Let it become a law so that it can protect the rights of the sick and give them a very compassionate care rather than throwing them into the prison.
Thank you guys for attending this webinar. All, the panel members, we're all really grateful for you attending and all those that contributed. I feel like even 1.5 hours is not enough. We almost need like a conference because the problem is quite huge. And I'm looking towards do we need to have a conference on this? But anyway, for now, we are going to get a summary of all the discussions. There is a recording of this webinar, which would be on our YouTube channel. So, and those that want to collaborate, because we have Concerned Medics Foundation, and it's looking into collaborating with doctors from diaspora and those in Nigeria. So, everybody is welcome to join. What else? I think, yes, it's been really, educative today and enlightening to know that, there's a way we can collaborate and help each other. So our next webinar is going to be next month, and we're looking at surgical, training in Nigeria, how, what is happening, what are the risks and all that. So do follow us and watch out for our webinar series, and follow us on YouTube channels and see all the previous webinars that have, taken place. But it's really exciting. Do leave your contact details and we can send you, direct recording of this. Thank you. Okay, bye.